and go.
Oh, sorry. So the question is asking which is the super disintegrant in tablets. I am losing my computer back. Yeah, so we have the cross camera. Very clearly. There's that one. There's starch, cellulose, calcium phosphate. And simple saying starch. Starch. Okay, so starch is a super disintegrant in. Okay. Usually have other disintegrants. Rather, what is cross camel loose? Niwatafutie basi. So cross-camerase gives dissolution and disintegration characteristics that's enhancing the availability in various formulations. I'm seeing it is an internally cross-linked sodium carboxymethylose for use as a super disintegrant in pharmaceutical formulations. Okay.
So why starch and not A, according to the thing that?
Yeah, why starch? I'm wondering the same.
I think based on what you've read, then it would be the cross camelose. I didn't know about the what capability of starch or such. I'm seeing someone has sent me something to my direct message. Let me just read it out.
Okay.
So it says the subtopic is super disintegrants. It says these are a class of excipients that are added to oral solid dosage forms such as tablets, capsules, and granules to promote rapid disintegration or breakdown into small particles after administration for facilitated rapid dissolution into GI fluid. Super disintegrants can swell up tenfold within 10 seconds. Within 30 seconds. Some examples are crosspovidone, crosscamelose, and sodium starch glycolate. Yeah. So crosspovidone, crosscamelose, and sodium starch glycolate. Those are the super disintegrants. I think just starch then is just a normal disintegrant. It doesn't count as super. Yeah, let me copy paste this and send it to the main chat.
Yeah, I think so what's the word for starch? Yeah, in this case, I think the answer goes to the cross camelose then. So what's the function of starch in tablets? Let's talk about the other ingredients like
as a disintegrant, and also I know it's used as a binder also.
It's a binder and also as a bulking to increase the bulk.
Yeah, as a bulking agent. Yeah, true.
Okay. What about cellulose?
Cellulose, I know it's also used as a binder, if I'm not wrong. These things, but I feel like cellulose is used everywhere, but I'm not sure of cellulose. Let me not.
Magnesium stearate. What was it used for?
as a lube or glidant.
Okay. The lubricant. What about calcium phosphates?
Phosphate, I'm not sure. Perhaps people can contribute the excipients, types of excipients, and common examples, right? While we are at this question, excipients and common examples of excipients, like the lubricants, the glidants, and all that.
Calcium phosphate is also used as a diluent.
Okay.
Dr. Sarafina shared a picture on the group which gives the types and examples really well.
Ah, nice. Okay, yeah. That one, see, basi tunaweza jisomea hiyo. If it's available. Let's question number 87. The efficacy of a clinical aerosol is dependent on its drug particles' ability to penetrate the respiratory tract. Which of the following drug particles are likely to produce more clinical effects? This topic. I love. So we have less than 0.5 micrometers, 79, 10 to 5, 2 to 6. I think it is more clinical.
Personally, I think D.
2 to 6.
Yeah, because I know less than 0.5, you like the particles are so small, so most times they usually remain suspended in the nose, and when they are too big, so above 6 and above, they are usually lodged in the upper respiratory tract, so they won't get all the way down because they're large particles. So personally, I think 2 to 6, because I think this is what we usually use for the nebulizers and all.
Okay, so
So I've Googled, it says particle size is the most important determinant of aerosol behavior. Small aerosol particles smaller than 5 micrometers in aerodynamic sizes are most likely to remain airborne for indefinite periods. So I don't know. I think it's 2 to 6.
Yeah, really is right.
So 2 to 6 is the best size. So if the smaller particles are likely to remain airborne for a longer time, the larger ones.
The smaller.
The smaller ones.
Yeah.
The smaller ones.
Yeah,
Okay,
so I'm
smaller ones are
thinking
likely to.
2 to 6,
Okay.
unless someone
Okay.
else has.
Anyone with a different opinion or a different research? Because I'm also finding similar things.
Yeah, I'm also finding the same thing. Maybe just to add on to what Dr. Sophia said. Here it's saying that particles with a diameter greater than 10 micrometers will be trapped in the trachea, whereas particles with a diameter of around 2 to 5 will be deposited within the bronchioles and alveoli. And then finally, particles with a diameter less than 1 micrometer will be inhaled to the lowest sections of the lungs, but are then exhaled, thereby providing no pharmacological effect. So they go deep, but no pharmacological effect because they will just be exhaled because of they're too small.
Mm.
Yeah, so it's
Okay.
just an add-on. Yeah.
Yeah, so the best optimal, depending on who you're targeting, is 2.6 for this question. If you're targeting the trachea, that will make sense for larger than 10. Right. The following processes are mainly used to improve powder flowability, except alteration of particle size and size distribution, that will alter it. Alteration of particle polymorphic form, alteration of surface forces, and alteration of particle size or texture. What do you think? Okay, the first one will alter the flowability. Surface forces will also alter flowability. Size, shape, texture. Yeah. What does polymorphic form mean?
I think when we are looking at powder flowability, a huge thing we need to consider is the fact that this powder and just flowability in itself is a physical process. So we tend to focus more on the physical characteristics. I think polymorphic is a sort of chemical change. If I'm not wrong, or what do you guys think? So yeah, personally I'd go with B because all the other ones are present. And then also when we're looking at this, I think it's also important that we also consider all the other these are characteristics of the powder itself. So just
polymorphic is a physical property.
Oh, so
yeah.
Polymorphism, discontinuous genetic variation.
Polymorphism might affect because if a substance changes its form from like a crystalline to an amorphous state, then it's more likely to be more soluble or have greater flowability. The amorphous state, the crystal.
Can you please go again, sorry?
Nasema because polymorphism mainly inaongelea vile substances or compounds you change their state from, say, a crystalline state to amorphous. So from a crystalline state would be less flowable compared to amorphous. Yeah, nini vile hizo compound vile ina interact because amorphous. Yeah.
Okay. So you're saying alteration of the particle polymorphic form will affect the powder flowability?
Yeah, I think it would.
Okay. Also, alteration of particle size and size distribution, that one does affect the powder flowability. Surface forces, I feel like the cohesion and those ones also affect the flowability.
Well, for polymorphism, would we consider crystals powders? Or just generally? Are they one of the same thing? Can crystals be powders? Maybe. Because if not, then even just generally, if we're saying a polymorphic form and the polymorphic form is a crystal, then are we really talking about powder flowability? I don't know if I'm making sense. What do you think, John?
Crystals are not powders.
Yeah,
Because
that's what I was thinking.
powders to some extent are dehydrated while crystals are hydrated.
Yeah. So
Okay,
yeah,
let's go
perfect.
to
Yeah.
factors that would affect powder flowability, but let's start with that. Things that would affect
Mhm.
powder flowability.
Yeah.
We have things such as the size tumesema that one is true, right? Let's eliminate the obvious ones. The size you agreed there. D, we have also eliminated it, right? Alteration of surface particle and texture. Because I don't remember it.
Yeah,
Jan,
even if you're just talking about sand, clay, loam, we
I was
can see
saying,
different.
Willie, there's something
Sorry.
sent in the group.
Oh, sorry.
Like the factors affecting, there's two pictures that have been sent and something. So there's a particle size from the diagram. The answer would be B.
The answer would be B.
Yeah.
Thank you.
Yeah.
Thank you, Dr. Brenda.
What does flow activators mean? From that picture. Let me read. They say that flow activators are commonly referred to as glidants. Flow activators improve the flowability of the powders by reducing adhesion and cohesion. Example will be talc, maize starch, and magnesium stearate. Thank you. Okay.
Okay, thanks. Daktari. So which one of the following are miscible? Ethanol and sugar, oil and vinegar, ethanol and water, iodine and water. Sas you're seeing as a choir because you guys know that one. Part two.
Hey, niambie.
Jibu hiyo, how don't you know it? You've been doing this chemistry.
Which ones are miscible?
Which ones are
Oh, are
miscible?
miscible. Yes, in ethanol and water.
Okay.
Mm.
I don't
Iko
know.
sawa.
I've never tried ethanol and sugar. Try it and tell us. Anyway, which one of the following alcohols is least soluble in water? So, tunasemanga, the longer the chain, the lower its solubility. So you have to go for the low.
Yeah.
Sure.
Yeah. So in this case, that goes to hexanol. Waxes are Yes. Gas liquid solution, gas solid. So the answer is solid solution. Solid solutions. Why? How? I'm just asking. Because it can't be gas. Okay. I guess the elimination. Can you look at pharmaceutical examples of, can you look at examples of pharmaceutical waxes and their uses? Yes, let us discuss waxes. Those who have any information about waxes, anything? Yeah. Because you may help us even understand how it's a solid solution. True.
Maybe
Thanks
also
to
when we're that,
Mhm.
also, I was also wondering if we can also share, I think, animal waxes and, the other general one. The plant, other plant waxes even. Yeah, but those
So
ones.
I'm thinking this is a combination. Let me see if they have been able to. I'm finding one, but it looks like it's a combination of all sorts of waxes. I will just specify which is which. But some examples, a beeswax, paraffin wax, microcrystalline wax, canuba wax. Common uses. They're used as texture agents, lubricants, or film coating agents. So the ones you use even in cosmetics, with lipstick, solid makeup, deodorant, soap. So for those ones who want a book, your animal waxes and plant waxes, somebody classify them for us, because if you found anything or if you have anything. Crickets.
So I've seen,
Mhm.
first of all, natural waxes. They're typically esters of fatty acids and long chain alcohols. The most common animal wax is beeswax. And what else am I seeing? Plant, there's something else I've seen. Paraffin wax is a synthetic wax derived from petroleum and refined by vacuum distillation. Yeah, so generally also remember the mainly esters, long chain hydrocarbons, and fatty acids. So they have those two. So that's one.
Anyone has anything else to add about wax? Somebody has shared a photo on the group with examples of the mineral waxes and the petroleum waxes.
Hello.
Huh?
Hello.
Yes,
Hello.
Mr. Level. Ongea.
Yeah, just talk.
Don't think he was talking to us. Hi, several types of waxes and with the associated essential. There's more information available. So, which of the following? Okay. Okay. Cerium sulfate is an ionic salt with a negative heat of solution. This implies that it will be. Let's talk about that. I feel like I have so many questions about that question. So this implies that it is less soluble at higher temperatures. So what does that mean? What does it mean by ionic salt with a negative heat of solution? What does it mean? Somebody to expound more on that one for us. Or to our chemistry.
Okay, from what I understood here, negative heat of solution, it means it's exothermic. It means when it reacts, whatever happens, it gives off heat at the end of the reaction. So that's why it's exothermic. So if it's exothermic, meaning the heat is a product, you get it, yeah? So if we add heat to the reaction, the number of products will be more. So in order to balance it out, the reaction will become a backward reaction. So it will become less soluble. That's less soluble at higher temperatures. Like, that's my understanding of it. Has it made sense? Yeah, because remember, endothermic reactions, you have to add heat for the reaction to occur. So meaning the heat is it's positive, it will be a positive heat of solution, and therefore the heat will be a reactant. So you add reactant, and since the amount of reactant is more than the product, in order to balance the equation, the reaction will move forward to produce more products. However, in this case, it's the reverse. Negative heat, meaning the heat, meaning it gives out heat, it's exothermic, so the heat is also a product of the reaction. So if we add more heat to the number of products, will be more than the reactant, so it will go backwards, making it less soluble. Yeah, that's makes sense, please.
So negative heat means it's exothermic.
Yeah.
Okay.
Yeah, just remember, like, whenever you see, like, when your result is like, when your heat product is negative, it means that the system itself lost heat, and that's the heat which is being given off to the environment. So whenever you have negative, yeah, so it's not the environment or the temperature you're checking, it's your system itself, like the reaction itself. Either it's gaining heat, and that's why you put the thermometer inside the reaction to see if it's, favorable.
Thank you for that. All right. So the next question. The ratio of the amount solid to mass of solvent is best described as molality, right?
Yes.
Yes.
Yeah. What is molarity? What is mole fraction? What is normality? Yeah, all there is. Let's define the other terms.
Molarity is the number of moles in a liter.
Okay. Well, how about the mole fraction? Or the normality? I didn't know about normality. What is normality? Normality. So according to Google, normality is described as a number of grams or moles equivalent of solute present in 1 liter of a solution. Okay, so it's like mole equivalent of solute present in 1 liter of a solution. And when we say equivalent, it's the number of moles of reactive units in a compound. Yeah. So that's the reactive. Okay. So any other question on number 1? Anything you want to discuss further? Okay, moving on. Which of the following reaction mechanism explains the incompatibility of tetracycline and antacid? Hydrolysis, completion,
Just a bit.
Okay.
So the way you are saying, so normality is now when we're talking about grams. So, for example, we know that 1 mole of HCl we have 1 mole of HCl, but HCl itself, if you add the components, I think chloride is 35.5 and hydrogen is 1. Sindio, 1 gram, 35.5. So 36.5 grams of HCl is 1 normality. Am I making sense? Are you getting? So ukiongeza hizo components for 1 mole, you get 1 normality. So 36.5 grams of HCl, or let's say 35.5 grams of chloride is 1 normal solution of chloride. Or 36, are you getting? So when you look at the grams and then you add their mass number, that's how you get normality.
Wait, Ebu guys, have you answered number 8?
Not yet.
We're going up. We're going like that up.
Yeah, I think the formula helps us understand what normality is. And I think somebody has sent it to the group. Normality is the time equivalent of the solid divided by the volume of solution. Yes, in normality. In Stanley has even given us the defect molarity versus normality. It's confusing. Molarity is the number of moles of a compound present in 1 liter of a solution. A normality of a solution is a gram equivalent weight of a solid in 1 liter. The one is giving more, the one is giving gram equivalent weight. And go on. Which of the following reaction mechanism explains the incompatibility of tetracycline and antacid? What do antacids do to tetracyclines? Why should you not take the two combined?
Is complexation. What is it? B. It complexes with the antacid since the antacids are they have all this like calcium or magnesium.
They form a complex. Okay. I also agree with that. I also agree with the complexion. That's how it's pronounced. Okay.
Is it also
what?
Is it also called chelation, or it's a different?
Yeah, it does. It's the same thing. Which is the same thing. They form insoluble complexes molecule due to the metal ion chelation with various antacids.
So the complex reaction forms chelates. The complex which are formed are called chelates, depending on the metal. If it's iron, it will form ion chelates. If it's magnesium, it will form.
Okay. Hydrolysis, racemic oxidation. Okay, are there other reactions or interactions that occur between drugs that may cause hydrolysis or oxidation that you know of? Silence. The following statement are about activation energy of chemical reactions except activation energy is a barrier reactants must cross to form products. At the peak of activation energy, various activated complexes are formed. Crossing of activation energy barrier by reactants depends on the temperature. Activation energy is always negative value. Yeah, it's not always negative value. Hmm. Okay, if you have questions or you need more clarifications on these chemistry questions, just unmute or type in the group. The following is true about half-life of a reaction, except the half-life of a second order reaction is proportional to the initial concentration. Half-life is the time required for half of the reactant to disappear. Half-life of a first order reaction is independent of the initial concentration. Half-life of a first order reaction, 12.5% of the substance remains after 3 half-lives. I guess for this question, you need to understand what is first order and second order reactions, which we can remind ourselves what they are. So what is our first order? What's a first order? I think we have gone through this a bit before, but somebody remind us what's a first order reaction and also like a second order reaction. And I think those, and also zero order reactions. Yeah. Okay. So the first order reaction is alcohol. I have a question. Alcohol, is it it's metabolic, is it a first order or a second order kind of thing?
But it was zero.
Alcohol. Because I remember there was a difference between when it's in little amounts and when you've taken a lot of it.
When you've taken a lot, alcohol is zero. That's why you see people like chai failing. But when you take a little, it's just first order. Yeah, so that you can maintain the euphoria.
Okay, so by that definition, explain to us what you mean by zero and first.
Me, I was talking about alcohol. Anyway, in zero order, wait, in relation to half-life, because this question is focused on half-life. In zero order, we are having a constant amount of drug or substance is being eliminated per unit time. That means your body, for example, eliminates 10 millimoles of alcohol every 1 hour. That doesn't change. Should you take 20 liters of alcohol or you take 1 liter? It will just eliminate 10 millimoles per hour. But in first order reaction, here half-life is more of your body eliminates a fraction of the drug per unit time. That means, for example, now in that case, we'll say every 4 hours, as we saw in a previous question, your body eliminates 50% of the drug. That means when you started drinking, your concentration was 100. After 4 hours, it will be 50. After another 4 hours, it will eliminate. So it will be 25% that way. So in zero order, constant amount. First order, constant fraction or percentage of a substance is being eliminated per unit time. I don't know how to explain for second order. I think Hiral was a star of second order.
Yeah, help us.
For second order, the rate reaction rate is 4 times the concentration or double the concentration for second order. But I don't know how the half-life would be affected.
Okay. Can try use.
Hey, but wait, what does that statement mean? It's 4 times the something.
As in, like, for example, like if you double the concentration, then the rate of reaction increases by a factor of 4. So for example, if you have the concentration of something is I don't know if I'm explaining it correctly, but if for example I'm trying to think of an example. Just wait just a moment.
Yes, Ira gives us an example.
I think
I
Pat, while she's one, or let's take, because Hiral is now, she's not explaining in terms of half-life, she's now explaining in terms of the reaction rates. She's brought the aspect of rate of reaction. So let's start with zero order. Perhaps that's how it can make the best sense. So sodium plus chloride gives sodium chloride. If assuming this is a zero order reaction, it would mean the concentration of sodium or chloride, it doesn't matter. That concentration will not affect the rate of formation of sodium chloride, right? We just need sodium and chloride to be somewhere, but their concentration, if they are in large amounts, if they're in small amounts, it really doesn't matter. The rate of the reaction will be a constant, okay? So that's zero order. But when we come to first order reactions, if we double the concentration of the reactants, we double the rate of the reaction. So in that case, still on sodium plus chloride, assuming it's first order reaction now, if we double the concentration of sodium, let's say before we were having sodium plus chloride, this is in a typical first order reaction. Let's say we had 0.5 molar of sodium. We had that sodium plus chloride giving sodium chloride, but the reaction, it was for sodium. So in a first order reaction, if we double the concentration of the reactants, let's now in our case, let's say we put 1 molar of sodium, we will double the rate of the reaction, meaning instead of it taking 10 minutes, it will take, okay? Instead of it taking 10 minutes, it will take 5 minutes. Now, for second order reaction is now the quadruplet. If we double the rate, if we double the concentration of sodium or chloride, the reaction will take place 4 times faster. In first order, it was taking place 2 times faster. Now, in second order, it will take just 4 times faster. That's why she said, if you double, you quadruple the rate of the reaction. I don't know if I've explained well.
Okay. Basi, based on what we know now, thanks for that, Gayat and Hiral. So, is the first answer true or false? The half-life of a second order reaction is proportional to the initial concentration. Now, since you said it's like if you increase the first one, it will affect the initial the final reaction. So does it make sense that the half-life of second order reaction is proportional to the initial concentration? Because that's why if you double, you double. Okay, let's put on. I want to know the answer. Let's go to B.
Is D, but I'm not sure.
D. For a first order reaction, 12.5% of the substance remains after 3 half-life.
But I think that's correct, no?
Yeah, based on what you said.
Yeah, D is correct.
Oh, it's correct. Oh, because I thought it would be 25%.
No, the first
No,
half,
that will be
after the first
100.
one will be 50,
Oh.
the second one will be 25, the third one will be 12.5.
Okay. Got it. Sorry.
According to the picture I've sent on the group, it summarizes how half-life works for each reaction, and it says if you increase the concentration for second order, the half-life will decrease. So that means they're not proportional. They're inversely proportional.
And what about choice C? The half-life of a first order reaction is independent of the initial
It is
concentration.
even if you
It's
increase the
independent, is it not?
no,
Okay,
it is
sorry.
independent. It is independent.
Yeah,
Even if
How
you increase
come?
concentration,
because guys just said
you can
like
just check the
it's
group.
fractions.
Because I thought C would apply to zero order, but let me check what you sent in the group.
Yeah.
First order, half-life of a first order reaction does not depend upon the concentration of the reactant. So it is independent of the initial concentration. Since it's a constant.
Okay, so then in that case, A is the one that makes sense, yeah?
Yes. And somebody else should have said, if the half-life, if they said, if you said it was not what is that word? Inversely proportional. What's the word you use, Sheena, to correct it?
Inversely proportional.
Proportional, yeah. So the half-life of second order reaction is inversely proportional to the initial concentration.
Before we go to the next question, Janet, number 79, I was wondering for the choice that we took, activation energy is always a negative value. If the question was, if the choice was activation energy is always a positive value, would that then be the answer? Or is activation energy always a positive value regardless of the value that we get at the end of the reaction in the system? Are you unanielewa? I'm wondering if the choice was activation energy is always a positive value. Would that still be the answer, or is activation energy always a positive value?
I think it's usually positive. Can it be negative? Can it be?
Yeah, that's not what I'm asking.
I don't think it can be negative. Like, okay, but I'm not sure. I'm not
I
sure.
actually
Let me
think
hear
it
from
can be
somebody else.
negative.
It can be
Why?
negative.
I think it can. I think.
Why?
What do you
Because
think?
here,
Yeah.
the choice A
Because
is
when we
saying
have the
activation.
exothermic and the endothermic reactions, then I think the activation energies would have opposite signs.
But those are just, is that the activation energy or the energy of the system at the end of the reaction? Because those are two, I think those are two different things. Because here in A, activation energy is a barrier reactants must cross to form the product. So I don't know, but I don't necessarily think activation energy and the energy you get at the end of the system are one and the same. That's one. And then if it's a barrier that must be crossed, then maybe it should always be positive. What do you guys think?
What is activation energy?
It's what A kenye imeandikwa tu hapo kwa A.
I feel like it's the
so it's the energy.
Activation energy is like actually what Willie is saying, because you have reactants and then they are supposed to react and then they form the product. So activation energy is the amount of energy that you need in order for the reactants to undergo the reaction successfully and form their products.
Yeah. So I always think that it cannot be negative, like it is always positive.
Yeah, because it doesn't make sense. How can you have negative energy to jumpstart a reaction? But you know, in science, things are different.
Yeah, I agree with you.
According to the other logic, I think scientific is saying, we have endothermic and exothermic reaction. Some require energy to react and some give out energy to react. If I'm not wrong, that's what she's saying.
Yeah, but that doesn't mean that the activation energy is negative. It just means like an exothermic reaction, it gives out energy, and an endothermic reaction, it consumes the energy.
Yeah. Even me, that's what I was thinking. I think when we say endothermic or exothermic, those are we're referring to
the reaction in general. The system, not the activation energy. Somebody talk.
Could you check the meaning of send in the chat?
Okay. Wait.
So I guess if you go by what was sent in the charts, so I'm thinking A would be the answer. Because
no. Like the answer is correct already. Like I was just wondering.
Correct.
Thank you,
But
Dr. Brenda.
let me ask Willie.
Yeah,
actually, sorry.
Yeah, but even me, I had the same train of thought as you. Like I completely get what you're saying. Even me, I was thinking the same. But yeah, so thank you, Brenda. Thank you, Saru.
Yeah. So based on what has been said to the group in Amanisha, there is a negative, a positive, and a zero energy. Activation energy. Okay. Next. The following statements are true about the rate of a chemical reaction, except the rate of, okay, the answer is the rate of reaction depends on the rate of change of concentration of reactants. Does not depend on the rate of change of concentration of reactant or product. Where are the others from? The rate of reaction depends on the equation. If the reaction proceeds in the forward direction, the rate of reaction is positive. If the reaction is at equilibrium, the rate of reaction is zero. Okay. So the one that's false is the rate of reaction does not depend on the rate of change of concentration of reactant or product.
I have a different opinion.
Okay.
Yeah, the answer, I'm on answer C, because when the rate of reaction, when the reaction is at equilibrium, the rate of the forward reaction is equal to the rate of the backward reaction, not that the rate of reaction is zero.
But I think D is also correct. Like the rate of reaction does not depend on the rate of change of the concentration of reactant or product. That can't be true, because for first order reaction, it is dependent, yeah?
No, those are, when we say first order, it matters to do with elimination.
That's just that type of reaction.
Yeah, so this
we classify it that way.
Yeah, this one is
You
just
cannot say
simply
But I
sodium
think for
plus
chemical
chloride.
reaction, definitely the rate of reaction will be dependent on the change of the concentration of the reactant or product.
Yeah,
Like what
definitely.
guys were saying, if you sodium plus chloride, you form sodium chloride, yeah. So I feel like if you change the concentrations of the side of the
definitely.
reactants, then it will change the side of the products as well. Mama?
You're right. Yeah. I think for choice C, as Dr. Kim was saying, yeah, he's right. Like the rates are the same, but then if you have a positive one and a negative one, I think it still equals to 0. So generally, we do know that in there, the rate of forward, like the forward rate and the backward rate of reaction are equal and they're occurring. But if you add 1 and minus 1, I think you get 0. And I think that's why C is true. Because, yeah, the rate of reaction is 0, but we do know we have a forward reaction taking place now, not backward reaction.
Thanks, Willie, for that. So, yeah. Which of the following equations describe second order reaction kinetics? Where A is the initial reactant concentration, it is a reactant concentration at time t. Equation. It is equal to I0 plus KT. Okay, that's a good revision. Oh, here I think we have done these questions before. 77 and upwards. Yeah.
Excuse Dr. Slim. I was wondering if you can, if somewhere in your database you have the previous test paper we used, and then you also share with us this one, and then we can
The answer
look
for
at them.
this one, while my other laptop and that one is damaged, so I don't have answers for these questions.
Oh, damn. I'm so sorry for that. So thanks.
Let me share another paper then.
We can take like a 5-minute break then as Shina looks for a paper. Aminoglycosides are mainly eliminated through the lungs, liver, skin, kidneys. Like the choir sang. Tutujibu Stanley. Dr. Bonner amesema through the kidneys. Give us examples of aminoglycosides. Anybody, quick fire. This is a quick fire. Hey. Na mnasema mko hapa nyi wote. Shafi, give us an example. Any. Kama bado tuko break. Aya. Gentamicin, kanamycin,
Dobramycin, neomycin, streptomycin.
Beautiful. So what are some of their common side effects? So are they known for? To cause. Eh? Okay. Ototoxicity.
Nephrotoxicity.
Beautifully done. Yeah. So which one had was notorious for causing a higher rate of ototoxicity?
Gentamicins.
I mean, yeah. Okay. Maybe mimi najichanganya hapa. But you're right. And what are they active against? What kind of bacteria are they active against? Anaerobic, gram positive, gram negative, are they against pseudomonas, like this kind of stuff.
Gram negative.
Aerobic or
gram
anaerobic?
negative. Yeah, and very few gram positives. I'm not sure of the examples.
So can you say it has a wide, what are they called? The ones which have a wide
Spectrum. Broad
spectrum.
spectrum.
Broad spectrum. Yeah.
Yeah, because they do they have activity. Okay, they have activity against the gram negative, the aerobic gram negative, and a few gram positive. And I think they also are they against pseudomonas? I think yeah. I think, I'm not sure. I think they're also effective against pseudomonas aeruginosa.
They're effective. Some even I think cobramycin is effective against Pseudomonas aeruginosa. I don't know.
Okay. So which of the following is an anti-pseudomonas penicillin? Okay. We need a crash course on this one. I remember them, but I have a big picture of them. Okay. Somebody to give a crash course on the penicillin, or rather the beta-lactams. Or anything you know about the beta-lactams. Okay, Bonaye ashatujibu yeye akasema penicillin. Bonaye. So, Dr. Bonaye, give us a crash course on penicillin. Maybe you already covered it and I was not around. Or Nugal. Haya, wacha nitafute niwapatie basi.
Okay, 1 minute. Let me look for the notes.
Okay, so
Okay. So for the classification, should I send to the group first? First is let me send to the group so that we can follow through. Okay, so for the first group, there's the narrow spectrum penicillins. You have the beta-lactamase sensitive, such as the first generation penicillin G, benzathine penicillin, procaine penicillin, and penicillin V. So for penicillin G, I think we had mentioned in the management of syphilis, if I'm not wrong. And also we use penicillin G and V for prophylaxis of rheumatic fever. Yeah. So I think you have mentioned these penicillins so many times, no need to. But yeah, for the next ones, they're the beta-lactamase resistant penicillin. So they are the cloxacillin, decloxacillin, flucloxacillin, and oxacillin. So for this group, they have a beta, what is it called? A bigger, bulkier group. So they are resistant to the beta-lactamase producing bacteria. And the most effective is the fluorocloxacillin. So for the first group that we did, the first generations, they are not effective against gram-positive, what is it called, Staph aureus. For the next group, which is the anti-staphylococcus second generation, they're effective against Staph aureus, but that's the Staph methicillin sensitive Staph aureus. So there's some bacteria stuff that has been resistant to this. For the third group, they are the extended spectrum aminopenicillins, which we use in mostly GIT infections and all that. So there's the amoxicillin and ampicillin. And then the fourth generation are carboxypenicillins and uridopenicillin. So these ones are the ones we call the anti-pseudomonal penicillins, in that the first generation that I mentioned, the second generation, and the third have no effective against Pseudomonas aeruginosa. But for the anti-Pseudomonas penicillins, such as carboxypenicillins and uridopenicillins, they're effective against the Pseudomonas aeruginosa. So for carboxypenicillin, we can remember with carbenicillin, anticacillin, and uridopenicillin. The most important is penicillin, piperacin, I mean. So you can remember uridopenicillin with the PP. Yeah.
Perfect, my respected senior. I can see Janet is having connectivity issues. I'm going to sub in for her for a few minutes.
Okay, guys, 1 minute. So I had said flucloxacillin is the most is it called most better absorption, of the most efficient in this class, because it means the more the beta-lactamase resistant drugs, the more chlorine group they have, the more halogens they have, the more better absorbing or better efficient. So flucloxacillin is the most efficient in this group. Yeah, and then I had said the bulky group. So for beta penicillin resistant, that's flucloxacillin. These ones, they have a bulky group. So and it's also orally active.
Great. Anyone else with something to add on penicillins? Perhaps you may have a burning point on penicillins that you feel it needs to be said. I think though Dr. Fatma has really covered them in detail. So moving on to number.
Sorry. Okay, then since you are at that, I think we can remind ourselves the beta-lactamase producing bacteria, since we are talking about that. So someone can give us a summary.
Can you also
Sorry?
beta, can you inhibitor No, like amoxicillin,
Really, I can't hear you. I don't know if it's my internet or
I'm
yours.
saying,
Mhm.
can we
Mhm.
share the data together with the drugs? No, yes,
I still haven't heard you. Guys, have you heard him?
No, it's very faint. Yeah, Willie, your voice is muffled.
Can you hear me?
Yeah, we can hear you at first and then you unapotea.
I'm saying, as we answer your question, can we also share the beta lactam?
We still can't hear you.
Then Willie, just type.
Let me type.
Meanwhile, someone can mention on the beta lactamase producing drugs. Not drugs, sorry, microbes. The beta lactamase producing microbes. Which ones are these?
I know E. coli, Staphylococcus aureus. There's also hemophilia influenza. I don't know Haemophilus influenza if it does too. And then Klebsiella pneumoniae, that's one also. That's the ones I remember. Also, Enterobacter species, are they beta lactamase bacteria? I'm not sure of that.
Okay, nice. So, yeah, anyone else with any other bacteria to add? Nugal,
Klebsiella pneumoniae.
Klebsiella pneumoniae.
H influenza, was it mentioned?
Yeah, H influenza, yeah. I'm not sure if it was mentioned. Let me see who's this. Stanley, I think in the same slides, there's a slide somewhere about at least having the beta lactamase producing drugs. Is it Stanley that has sent these ones for you? Shafi. Shafi.
The beta lactamase inhibitors, the clavulanic acid and all that.
Yeah.
Oh, okay. So the examples include sulbactam, tazobactam, and clavulanic acid. So how they work is that they mimic the beta lactamase. They have a beta lactam ring, whatever. So they bind with the beta lactamase, and then they cause suicide inhibition. Let me be corrected if I'm wrong. And so when it causes suicide inhibition, it inhibits beta lactamase, right? So the drugs can work better because the whole point that they were not working is because they were being inactivated by beta lactamase. Yeah, so it was through suicide inhibition, I think. I'm not really sure of that mechanism. But those are the examples.
Perfect. Yeah. Willie says, thank you, Dr. You're a blessing to be here. So penicillins, I believe we've covered them in detail, and I'm sure we'll find more questions on penicillins just among the remaining past papers. So moving on to number 191, the question is,
have you guys covered some of the notorious lactamase producing bacteria? I think I was kicked out.
Yeah, and I think someone has also sent something on the group regarding the same.
Okay, thanks.
Yeah. So next question asks, streptokinase dash acts by inhibiting vitamin K metabolism, blocks the incorporation of vitamin B, is a fibrinolytic agent, is not an enzyme. What is streptokinase? What is streptokinase? So based
fibrinolytic.
It's a fibrinolytic. Great. It's a fibrinolytic. What's
So,
its mechanism?
Yeah, so it activates, it converts plasminogen into plasmin, and now this plasmin can degrade our fibrins, the fibrins present, and therefore prevent. So it breaks them down, which is different from antithrombic, because now for antithrombic, now we prevent the formation of fibrin, while here we are actively breaking down. Once we say lysis or a lytic agent, we are definitely saying that something is breaking something down.
Perfect. Any other drugs that are also in this class? Any other drugs in this class as streptokinase, the fibrinolytics?
Is the urokinase.
Urokinase from urine.
Then the alteplase, which is commonly used.
Yeah, the alteplase, commonly used for especially stroke. Yeah. Then what's the major limitation for streptokinase that it kind of makes it unique from urokinase, from alteplase, based on its source? Something about streptokinase. It sounds like streptococcus. So based on its source.
It's derived from bacteria.
Produced by bacteria.
Yeah, it's produced by bacteria. So your body can develop antibodies against streptokinase and lead it to not function. Yeah. I was looking for the same. I've not found where, but yeah, your body can develop antibodies against that streptokinase. Anticoagulants, we've covered them before, I believe. Shrina, maybe you can confirm. Anticoagulants, antiplatelets, have we covered them?
I remember doing antifibrinolytics and coagulation. I think.
Yeah, we did, but like we didn't understand. We were just reading. Maybe someone can give us a good summary.
Perfect. I think Brenda can give us a summary on that.
On what?
Anticoagulants, antiplatelets, such, drugs used to prevent thrombus formation and such things.
I'll talk about a few, maybe someone can help me with the rest. So we have the categories of anticoagulants. We have some which are parenteral, others which are oral. The parenteral ones will include the likes of the heparin, that is the low weight molecular heparin, the fondaparin nux. This one will work by inhibiting. They'll first bind to antithrombin 3, and then the complex is what will inhibit factor 10A. And then we have the oral ones. We have the likes of the coumarin derivatives, such as warfarin. We have also some oral direct thrombin inhibitors, such as dabigatran. We have a direct factor 10A inhibitor, which is rivaroxaban. Yeah, and now heparin. Yeah. Someone else can add.
Okay. Yeah, Perhaps someone can add on antiplatelets. She's majorly covered on the anticoagulants. Someone can mention antiplatelets and tell us what's the difference between anticoagulants and antiplatelets, if there is a difference.
I think antiplatelets, it's to inhibit the adherence of the platelets to the blood vessel.
Nice. And anticoagulants?
Anticoagulants will now work on the clotting factors. Like heparin, it works on factor 10.
Yeah, perfect.
But they both they inhibit clot formation and clot propagation. They will not dissolve the clot, those two, antiplatelets and anticoagulants. But it's now the thrombolytics like this alteplase will now dissolve the clot or break down the clot.
Yeah, in short, anticoagulants, they're primary preventions, and antiplatelets, they're secondary preventions, because anticoagulants, they're effective in thrombosis in both the venous and the arterial system. And antiplatelets, they're effective in the arterial circulations. They have little effect in venous circulation. Antiplatelets.
Anyone else with something to add on the same?
But please repeat that. You said for venous circulation, what?
I said anticoagulants, they're effective in the prevention and treatment of thrombosis in both venous and arterial systems. And antiplatelets, they're effective in the arterial circulation only.
Thank you.
Moving on. Perhaps this anything on the chat box? Nothing. Okay. So question 191. Labor can be induced by administration of agometrine, oxytocin, vasopressin, or prostaglandin F. Which drug do we use to induce labor? Divya is saying oxytocin is a drug used to induce labor. Oxytocin is the drug used to induce labor. What's the role of agometrine in, let me say, in giving birth? Does it have any role?
Doesn't it prevent postpartum hemorrhage, and also it acts as an oxytocin or something? But I'm sure about the preventing postpartum hemorrhage. The other one, I'm not sure.
Yeah, postpartum hemorrhage. Yeah. Oh, Divya is saying delivery of the placenta. I don't know about that. I know majorly is for postpartum hemorrhage. Or she's asking. Okay.
It's given after delivery of the placenta.
Yes, it's given after delivery of the placenta to prevent excessive bleeding.
So agometrine will be given after delivery of the placenta.
Yes.
Thank you for that critical information. Anyone with something to add on labor, anything labor related, pregnancy, on the same lines? think the other day we talked on tocolytics, the drugs that prevent or prolong or prevent that premature labor. So I think hapo tuko sawa. Moving on to the next question. All of the following can be classified as uncontroversial risk factors for NSAIDs, ulcers except. All the following can be classified as uncontroversial risk factors for NSAIDs, ulcers except previous peptic ulceration, concomitant corticosteroids or anticoagulant use, cardiovascular disease, Helicobacter pylori. So I think the first exam here is to understand what is an uncontroversial risk factor. When you understand that, perhaps someone can explain what that means. Meanwhile, I'll be reading this message from Nugal. It says that agometrin is used in expulsion of placenta after delivery. Agometrin is used in expulsion of placenta after delivery. That is from Dr. Nugal. Yeah. So on number one, just be classified as uncontroversial risk factors for NSAIDs, ulcers except. So all are uncontroversial risk factors except. Personally, I'd go with cardiovascular disease. But I really don't understand what that term means, uncontroversial risk factors. But looking at the choices, previous peptic ulceration means that you may be at risk for another ulcer formation. Choice B, corticosteroids and NSAIDs, even corticosteroids themselves, they do increase the chances of ulcer formation. And then Helicobacter pylori causes ulcers. So based on elimination, I'd go with the cardiovascular disease, but I don't understand what uncontroversial risk factors means.
NSAIDs does not cause Helicobacter pylori, but it can be a cause of cardiovascular diseases. So the answer there is just Helicobacter pylori, which is a bacteria, not from NSAIDs.
So what's the question asking? What's the definition or what's the understanding of uncontroversial risk factors?
In Google, it's saying the risk factors that are not within our control, something hereditary.
Okay, so based on that, but yeah, H. pylori. Moving on to number 193. Someone has something to add on NSAIDs and ulcers, or even on the topic of ulcers as a whole?
I just have a question. I haven't really understood. So cardiovascular diseases, if you have a cardiovascular disease, it will increase the risk of having ulcers, just generally fast.
No.
So how is it? Because the other ones I've understood, and I sort of get why H. pylori, because H. pylori mostly it's for the stomach ulcers, and then the duodenal, those are mainly caused by the NSAIDs. But I'm not understanding how C is not the answer. How is cardiovascular disease a risk factor, even just generally for to have ulcers? I'm not. Maybe someone can share.
Ama perhaps, you know, Rebecca, perhaps you can explain just that term, uncontroversial risk factors. Not, I know Shafi has read what Google has said, but Rebecca, perhaps you can explain in your understanding. You know, it will be much easier from your side.
You know, because I was thinking the previous peptic ulcerations, obviously now the NSAIDs will affect. If you have corticosteroids and NSAIDs, that's a problem. But for C, I'm not really understanding. Maybe she can share. Because I think all the others are actual risk factors which can promote. Yeah, except
Oh, see, then cardiovascular disease has no relation with ulcers.
That's what I'm thinking. Yeah. So for me,
Give it some degree. After taking, even we were using a drug like aspirin.
Gauss. I think this is an English question, not a scientific question.
And Donatam to explain that stuff.
Yeah, so what I'm thinking is uncontroversial. Yeah, hiyo inamaanisha ni gani yenye, okay, from my simple understanding, ni gani yenye in case it happens, it won't be confused with another. But if you think about when they say except, so which one is a controversial risk factor? H. pylori will be the controversial risk factor because hujui kama ni H. pylori ime cause the ulcer ama the person has been taking the steroid that caused the ulcer. So there's a controversy. Is it the H. pylori or is it the NSAID? But for the cardiovascular disease, it's uncontroversial because, as you know, NSAIDs, for example, like what? Aspirin NSAIDs, no?
Yeah.
Yeah, if aspirin is an NSAID and someone is using it for its cardioprotective ninis, it can cause the ulcer. Sindio?
No.
Yeah. So it's more of an English question than a scientific question.
Yeah, that's a really, really good explanation. Thank you, Dr. Patrick. Nice.
No problem.
Asante. That's Dr. Patrick is an expert on the Queen's language. Yeah.
Stop flattering me. Stop flattering me.
So number 193. All of the following factors play a role in the pathogenesis of inflammatory bowel disease, except all of the following factors play a role in the pathogenesis of IBD, except smoking, stress, genetics, or appendectomy.
Gaius, a minute. For question 192. After the end says there's an ulcers part up with, I think we're ignoring that. Because how will cardiovascular disease lead to ulcers when using NSAIDs?
That's what Patrick was explaining. For example, you're on a drug like aspirin, cardiovascular.
So we're just generalizing that everyone with cardiovascular disease could be on aspirin.
Yeah, an assumption that you're probably on NSAID. Yeah, it has a predisposed to the
Okay. Again, it's all about the Queen's language. All about the Queen's language. So number 193, I think we can all agree upon the appendectomy, right? Then Nightwing. I know you're an expert on IBD.
Have you gotten the explanation on cardiovascular diseases causing ulcers?
No, we have not. I'm a Patrick.
With cardiovascular diseases, there is low perfusion of the tissues, reaching a different type of tissue, which can cause the tissues to start to break down, causing an ulcer that can develop, especially with the NSAIDs, aspirin, even with low doses with aspirin. But with the Helicobacter pylori, it is a bacteria that is causing this ulcer already, not the NSAIDs that are being used in cardiovascular diseases. So Helicobacter pylori can itself cause ulcer, but all the others are controversial as risk factors of NSAIDs. Whether it is the cardiovascular disease itself, it will limit the oxygen perfusion to the tissues. The tissues themselves, they will start to break down, causing an ulcer.
Rebecca?
Yes?
Yeah, your point is valid, but for that specific question, yeah, we're looking at the controversial risk. And why we are going with Helicobacter is when you have Helicobacter and you're using NSAID, yeah? As you know, Helicobacter can lay dormant before it starts acting up, right?
Yes.
Yeah, so sometimes the reason why we're saying Helicobacter is a controversial one, you may not know if it's the NSAID use that has caused the ulcer or it's the Helicobacter that has caused the ulcer. So that's why we're saying it's the controversial one. And you know, as if the question is uncontroversial risk factors except. So the except means which one is a controversial one?
It's okay.
Yeah.
Perfect. I hope Sunshine, we are on the same page. I think number 192 is H. pylori, Dr. Shrina. Yeah.
Yeah.
What have you said?
It is true, it is D.
Yeah, H. pylori. So, Nitwing, you are to give us the scoop on IBD.
Give me a minute. One second, guys. Yeah, so just a quick summary. So with IBD, it usually encompasses two diseases. This is ulcerative colitis and Crohn's disease. So I think they have almost similar symptoms. Almost. Because with ulcerative colitis, you find that diarrhea is common. Mainly, it's going to be bloody, watery, or mucopurulent. It's also coupled with rectal bleeding, abdominal pains, cramping, weight loss, and malnutrition. Also, tenesmus and constipation. So with Crohn's, we have diarrhea that's less bloody than that in ulcerative colitis. Rectal bleeding is also there, but it's to a lesser degree than in ulcerative colitis. We also have abdominal cramping, weight loss, and malnutrition. That's more common than that in ulcerative colitis. Yeah, and then the other thing to find is maybe non-specific signs like fever, tachycardia, dehydration, and more localized tenderness. For the lab, for the diagnosis, mostly not specific, but we could do the CRP test and also fecal occult blood. Yeah. So, and also, yeah, the same for both ulcerative colitis and Crohn's disease. Then going to the treatment. Treatment here mainly because it's more of a chronic disease. You're mainly looking at long-term. You're looking at long-term goals, such as remission, and also to improve quality of life to prevent relapse. Yeah, and here we have some non-pharmacologic and pharmacologic modalities. So for the pharmacologic, it usually involves some dietary restrictions, yeah, like cutting down on dietary fats, foods with these detoxifying agents, and also increasing the vitamin and mineral supplementation. Yeah. Something else, okay, looking at the pharmacologic therapy. Here we can treat symptomatically. For the diarrhea, you give anti-diarrhea agents, the anti-motility, such as loperamide. Also, you could give atropine. Yeah. Yeah. And codeine should not be given in people with active IBD because it can worsen the situation due to the propensity to cause the toxic megacolon. Then we have other drug classes such as aminosalicylate. Here we have a drug like 5-aminosalicylate, 5-ASA, and mesalamine. This one's I think mainly they act on the inflammation. Then we also have the corticosteroids. These ones are mainly to suppress the IBD, also the inflammatory process. And also they have been shown to improve the symptoms and disease severity. But then you also want to be cautious about the risk factor for the adverse effects with the chronic use of corticosteroids, such as osteoporosis, the risk for cataract, skin atrophy. Yeah. And then we have another class of agents called the immunomodulators or the immunosuppressants. Here we have a drug like azathioprine or the 6-mercaptopurine, which mainly work by inhibiting the purine synthesis and also reduce IBD associated inflammation. For the duration, not sure about the duration. Yeah, and also another drug is methotrexate, which we had looked at anti-cancer. It's a folate antagonist. We also have another drug like cyclosporine, which is an immunosuppressant. And we could also give biologics. Here we have classes which target the tumor necrosis factor alpha, and they include drugs like those that end with the suffix mab, like cetolizumab, adalimumab, and golimumab. So I think, but then also something else that's important is to classify individualize the treatment based on the low risk, high risk, and the low risk and the high risk patient. For the low risk, we have there is an inductive therapy and we have mesalamine. And for the high risk, we have the systemic corticosteroid, and we maintain with thioprin corticosteroid over 60, and then later you can also give the anti-tumor process factor agent. You can look at, I'll send whatever the treatment I'll go to. Or if anyone can send it to the group. Yeah, that's it. That's it.
Hey,
Yeah.
Between ulcerative colitis and Crohn's disease, which one is common in smokers? There was one which is common in smokers.
Crohn's is worsened by smoking.
Yeah, I think it has a protective role in.
Okay.
Yes, protective for ulcerative colitis.
Kwa hivyo guys, hapo uko safe.
Thank you.
Can say the same for other risk factors.
Thank you, Nightwing. And I think our time has come. It's 10 p.m. and we'll stop here to continue tomorrow at 10 a.m. Right? So you have a 12-hour break.